All right, good morning. I'd like to start with the case presentation. Our patient is a 7-year-old female with a history of L1 level myelodysplasia who underwent repair at birth. She also has associated cardiac malformation and shunted hydrocephalus. The patient came to us in 2011 where orthopedics diagnosed her with early onset scoliosis at the age of 3 due to neuromuscular etiology. She also has associated left hip dislocation and dysplasia. X-rays show a left thoracolumbar curve measuring 75 degrees that corrected to 45 degrees in a sure step TLSO brace. There's no vertebral hemivertebra, fusions, or bars noted. We followed the patient serially with radiographs. When she was age 5, she had significant progression in her brace to about 70 degrees, and a Boston TLSO brace was recommended. Surgery was discussed, but the parents were not willing at that time. When the patient was 6 years old, she followed up and again had some progression in the brace. Mom was noting worsening clinical deformity, and again we discussed growing rod placement, but surgery was deferred. Finally, when the patient was 7 years of age, the curve progressed over 70 degrees in her brace, and the decision was made to proceed with surgery. So today I'll be talking about treatment options for early onset scoliosis. This condition is defined as a three-dimensional deformity with lateral curves of the spine greater than 10 degrees that is not present at birth but diagnosed before or during age 5. This is a diagnosis of age of onset rather than etiology, and there's multiple causes that can lead to early onset scoliosis. This includes infantile idiopathic scoliosis, which is diagnosed from age 0 to 3 years, juvenile idiopathic scoliosis, is diagnosed from age 4 to 8 years. It can also be caused by neuromuscular conditions as well as syndromes. This differs from the traditional late onset scoliosis because these patients have increased risk of progression, about 5 degrees per year with idiopathic infantile compared to about 1 degree per year in adolescents. These patients have worse prognosis with more severe curves at maturity and can even have can be a fatal condition due to cardiac and pulmonary compromise. The natural history of this disease is one of tendency towards progression. James was one of the first to really study these patients, and he followed 43 idiopathic infantile scoliosis patients. They had about a 7-degree curve by age 10, with some of these curves being over 100 degrees. Scott and Morgan similarly followed about 14 patients until maturity, and they found a mean curve of these patients of 120 degrees. 3 patients even died before the age of 30 due to cardiac and pulmonary complications. They found these curves were of 2 types, one that could either progress or one that could spontaneously resolve. So to help differentiate the 2 curves, one of progression and one of resolution, Mudd in a 1972 paper looked at radiographic parameters to help identify curves that would progress. She looked at 2 things, and one was the relationship of the rib head to the apical vertebral body. A phase 2 rib was defined as a rib with overlap between the head and the body on the convex side, as you can see in the diagram in the upper left. A phase 1 rib was no overlap between the rib head and the body. Patients with a phase 2 rib had increased risk of progression, but patients with a phase 1 rib, they measured the difference between the angle of the convex rib and the concave rib in relation to a line perpendicular to the apical vertebral body. A difference of these 2 angles greater than 20 degrees had a high incidence of progression, and a difference less than 20 degrees had a low incidence of progression or tended to resolve. Dobbs and colleagues looked at a multi-center prospective study, and they MRI'd patients without any neurologic findings, and they found 22% incidence of abnormal findings in the MRI of these EOS patients. When talking about curve progression, the phase of the rib and the rib-rectangle angle difference really only apply to infantile idiopathic scoliosis patients, and these are inappropriate in your patients with myelodysplasia or cerebral palsy. Patients with these conditions, the deformity is really driven by their associated neurologic malformations such as Chiari malformation, tethered cord, or hydrocephalus. In patients with cerebral palsy, they have persistence of their primitive reflexes, hyperspasticity, and hip contractures that can also lead to scoliosis and curve progression. You can imagine with these severe curve deformities, about 120 degrees at skeletal maturity, that they could have some pulmonary compromise. We know that patients' alveolar development is usually completed by the age of 8, and at age 10, you have half of your adult thoracic lung volume. You can see from the top left image that most of your lung development and your alveoli development occur from the age of 0 to 5 to 8 years of life. In addition, once the curve progresses to severity, Campbell and colleagues identified a condition called thoracic insufficiency syndrome. This is the inability of your thorax to support normal respiration and lung growth, and can be fatal. So when talking about treatment considerations in these patients, traditionally these patients underwent a definitive anterior and posterior fusion. The belief was that a short, straight spine was better than a long, deformed one. However, we quickly found that these patients had increased respiratory failure and even death, And now our treatment focuses on development of the spine, chest wall, and lung development as a combination. We also look at our T1 to S1 length, and this increases rapidly in the first 5 years of life, is latent from years 5 to 10, and then increases again around puberty. We want to avoid interfering with this early growth curve and try and maximize the spinal height. We know that a T1 to T12 height of at least 18 centimeters indicates better pulmonary function and skeletal maturity in these patients. Really, the goal of our treatment is to try and alter the natural history of curve progression and even avoid this certain pulmonary demise. So when talking about treatment options, we always want to start conservative, and certainly a period of observation is acceptable in these patients. However, once there's documented curve progression, over 25 degrees, and with low magnitude curves, and in our idiopathic patients, if they have a phase 2 rib or RVAD greater than 20, we certainly want to think about intervening to help delay or limit the progression of the curve. And this can involve casting. There's 3 different types. You can see the risser on the bottom right, which is a 3-point mold. You can see the derotational casting in the middle, and then the cantilever bending in the bottom left. These are also not without complication, as these can lead to pressure ulcers. And early reports showed that there was malformations of the rib as even the mandible with casting techniques. Another non-surgical option is traction. This is a nice preoperative non-surgical means to help increase our pulmonary function up to 20% in some studies and help reduce complications postoperatively. It allows for spinal creep through continued longitudinal traction of the spine prior to other treatments. However, this also has its own set of complications associated with pin sites. When talking about surgery for these patients, it's a 3-dimensional deformity, but most of the techniques involve distraction and one deformity in the longitudinal plane. The first technique was really the growing rod concept, and this was 1 to 2 rods that was fixed proximally and distally using a combination of hooks, claws, or pedicle screws. The rods were then tunneled submuscularly or even subcutaneously and intentionally left long. This technique describes the use of end-to-end connector or intercirculatory box, and through which the surgical lengthenings are performed every 4 to 6 months. This surgery was initially met with a high complication rate, mostly due to use of 1 versus 2 rods and certain types of fixation. These patients are also at risk for undergoing spontaneous fusion, which, as you can imagine, will really limit your ability to lengthen these patients and kind of undermines your overall treatment goals of getting good spinal growth. There are also the law of diminishing returns that some authors state that as you undergo more and more lengthenings, it gets more and more difficult to achieve the desired length. Akbarni and colleagues in 2005 reported the largest series of these patients. They looked at 23 multi-center patients. They had significant correction in the coronal plane, but these patients required a mean 6.6 lengthenings every 6 months. They did increase the space available for the lung, but they had a 56% complication rate reported. One of the next treatments we'll talk about is the vector lengthening and the vertical expanding prosthetic titanium rib. This allows different modes of fixation. It can be spine to spine, rib to rib, or rib to spine. The surgical lengthening, again, similar to the growing rod concept, is performed every 4 to 6 months and does require repeat anesthesia and a trip to the operating room. Hausler and colleagues looked at 23 patients with onset scoliosis treated with this device. They again had good coronal correction, increased the space available for the lung, but the complication rates reported with this technique have been reported as 100 to even 193%. Similar to the growing rod concept, this again requires a repeat trip to the operating room to perform the surgical lengthening. In looking at a guided growth concept, this was initially described by Dr. McCarthy and is named after a hotel in Seoul, South Korea, called the Shilla technique. This involves pedicle fixation at the apex, and you actually correct the 3D deformity at the apex, and you fuse this 3 to 4 levels. There's then 4 to 6 pedicle screws placed proximally and distally, and this is done percutaneously to minimize disruption to the periosteum and avoid that premature fusion. The screw caps capture the rod, but they don't engage it, as you can see in the picture on the left. This allows these segments and these screws to slide along the rod as the patient grows. This allows the patient to grow without the need for repeated surgical lengthenings. McCarthy just reported his 7-year results in JBJS in 2015. This included patients of all kinds of etiologies. The index surgery was around 7 years of age, and they had excellent coronal correction. They also increased the space available for the lung, but you can see that these patients also had 73% reported complications. These were complications that necessitated a repeat trip to the operating room. However, these patients required 77 surgeries to maintain their treatment, as opposed to the 289 projected that they would need if they had lengthenings every 6 months. Overall, 73% reduction in surgery for the care of these patients. One of the newer technologies in the market is the magic rod. This is a magnetically controlled lengthening rod. It's fixed at the proximal and distal ends of the curve, and the rod is then tunneled submuscular or subcutaneously, and the lengthenings for this rod are performed as an outpatient in the clinic setting via remote control. LaRosa and colleagues reported some results on 10 patients in 2015 with 27-month follow-up. Again, they had good coronal correction. They had almost 6 centimeters of mean lengthening from T1 to S1 over this follow-up period, and they reported a little bit lower, but again, a 30% complication rate with this implant. In addition, Jenks and colleagues looked at a cost analysis, and they analyzed that there was a $17,000 cost savings per patient over a 6-year span, taking into account that these patients did not need to return to the operating room for repeat lengthenings. So coming back to our case presentation, we had our 7-year-old girl with the EOS. Back in November 2015, she agreed to undergo surgery and dual magic growing rods were placed. We instrumented from T2 to the pelvis. We did anterior and posterior spinal fusion from L3 to S1. Fortunately, her case was complicated by wound breakdown necessitating flap coverage and debridement by plastic surgery, but at her 3-month follow-up, she was doing quite well with a healed wound, and she was ready for her first lengthening. You can see the lengthening device in the top left corner, and then there's the magnet localizer in the bottom left. So outpatient lengthening was performed. Let's see if we can get going. This procedure is painless. It's done in the outpatient clinic. It takes about 30 seconds to complete. We were able to achieve 4 millimeters of lengthening at this clinic visit. Nice shot, Dr. Lark there. And this procedure takes 30 seconds. It's done about every 3 months, and you can see it's relatively painless for the physician and the patient. I don't know if you can hear the magnet going. And that's all it takes. So I'd like to thank Dr. Lark, Dr. Fitch, and Dr. Allman. In summary, early onset scoliosis is a coronal deformity of greater than 10 degrees with onset at or before age 5, and if left untreated, has the potential to be fatal. Radiographic parameters such as the RVAD or the phase of the rib can help identify progression in the idiopathic patients alone, but not in neuromuscular or the syndromic patients. The surgical treatment is not only aimed at maximizing spinal growth, but also allowing for lung development and chest wall capacity. Our current treatments certainly have a high associated complication rate, as I've pointed out, but these can alter the natural course of the disease and give these patients increased spaceability for the lung as well as spinal height. Newer advances may provide equal or better results, hopefully with decreased morbidity and cost. So just to open up for some questions for discussion, what age really constitute EOS? When you look in the literature, some studies define it as age 3, age 5, age 8, or even recently as before age 10 years old. And these correlate with the lung development, with the maximal spinal growth. When would you obtain MRI imaging in these patients? Do you use it after curve has progressed, if there's abnormal physical findings? Or what about these patients who have no abnormal physical exam findings? And then finally, when would you initiate casting? And then what's your preferred operative technique and why? Okay. Shooting from the wall.
So first of all, that was a fantastic talk, Mitch. I don't know how the heck you got through every bit of that in less than 15 minutes. This is a lot of information to cover. Because like you said, early onset scoliosis is really kind of a catch-all term for a lot of different etiologies of scoliosis. It's just based on age. So most of the literature I'm familiar with defines early onset scoliosis as prior to age 5. But I do think lung development is still occurring at that age, so it'd be interesting to hear what the others think about that particular random age cutoff.
So I agree. I think that the difference in early onset, I like Bob Campbell's way of thinking about it. So Bob Campbell's the one who first did the rib distraction. And it's really, that was the age where the lung is way more important than the spine. So I like the way he thinks about this as a problem where you're trying to treat the chest wall, and the curve is secondary. So in those cases where the chest wall is more important, that's really what I think about it. And it's more, it's like DDH. You get most of the development up to 4, and then from 4 to 6 you get a little bit, so you have a gray zone where you want to put your division. So what do you think?
I agree with that completely. If they're 8 when they're diagnosed, pretty much, delay tactics, standard techniques, that's not the one that's going to give you the headaches and be the really problematic patients. So yeah, probably 5 or under, I would say. I don't know if you necessarily have to have an exact age. Early onset is going to be the patient that's going to require these difficult strategies, traction and delayed tactics and things like this.
When do you think, your next one is, when do you get an MRI? When do you think you should get an MRI?
So usually these patients are hard because you have those factors and then usually require some sedation or anesthesia. The study I quoted by Dobbs, they found 22% abnormal findings in these patients who had a completely normal physical exam, and then I think only 8 of those patients went on to require any kind of surgical intervention. I think if you have abnormal physical findings, so abnormal abdominal reflexes, for example, or for progression, I would probably get MRI at that point.
What if they had congenital malformations of the vertebra? Would that change your mind? Because you got early onset scoliosis can have spondylocostal dysplasia, all these congenital abnormalities.
Yeah, that's true. So in the literature I looked at least, they separated those patients, not from EOS. They kind of termed those as,
So I think this is the complexity with this, because early onset scoliosis is scoliosis below an age. It can have all the different etiologies like anything else. So my advice is to get the MRIs based on what you do for the etiology, not based on the age of the patient. And for some patients, you want to get early scoliosis, but you probably wouldn't need them on all of them. You're not making sure.
Yeah, personally, I tend to get an MRI if a patient has shown curve progression, or if they show me some other reason to get an MRI, like you said, some type of abnormal physical finding, asymmetric reflexes, etc. Dr. Fisher, the master clinician here. What's your,
Yeah, I agree. I mean, obviously, if you have physical exam findings demonstrating a neurologic deficit of some type or some neurologic findings, even subtle spasticity, whatever, that certainly warrants it. Mild curves that are stable, I don't think you need to jump on obtaining an MRI, except maybe in the infantile patient. You have if you're perhaps in that scenario where you're not sure about an infantile patient, whether they are going to be truly infantile idiopathic or there's something seriously, could be some brainstem issue. So maybe occasionally, but I'd say I agree majority of the time, normal neurologic findings, non-progressive curves, I would delay obtaining an MRI.
So with regards to casting, we typically think of casting predominantly for the infantile idiopathics. There's pretty good literature, at least in the congenital, that it can be a delay tactic, but can't necessarily be curative. As far as an initiation of casting, there's a couple of things that you mentioned in your presentation. So curves that you know have a high chance of progression, so those with an RPAT more than 20 degrees or a phase 2 rib, those are patients that I would consider casting, and also those that, again, have shown documented progression. So Dr. Allman, what's your favorite casting technique?
Yeah, I like to use like Meta's technique of using a true RISR cast. You like to hang the patients from the ceiling, so which is they'll be fine until one of the OR legs falls down, and you'll be in trouble.
Engineering, I like that.
But I don't think it. I think they both do the same thing. They're both different ways of getting, just different ways of holding the patient to get the same approach.
Dr. Did you have any pearls for casting?
Well, I think that probably the occasional cast I've seen that's done with this cantilever technique, it's not the same cast as done with the traction technique. So you had, in order to for the RISR cast to work, you have to have control of the pelvis. So you have to have, it has to go low and high. It has to be shaped like a sort of Boston TLSO with kind of higher trim lines, and you have to grab the pelvis to maintain the distraction. It's cantilever bending technique. Perhaps the casting doesn't need to be quite as precise, or I don't know what the term would be. But
You could theoretically, though, have them how like that still rotate the pelvis when you make it.
yeah, and you can definitely grab the pelvis with either technique. So I don't really have any experience with the cantilever bending technique, but I've just seen radiographs of patients that Rob has treated, and I think the results are quite good, but certainly comparable to the other techniques.
Yeah, it's actually something we were talking about doing a study looking at just the radiographic comparison of the two techniques.
Then as far as the surgery goes, I mean, we can spend 5 hours talking about that because it's such an individualized treatment plan for these patients. You have to consider what their infection risk is going to be if you're going to choose a procedure that requires them to go back to the operating multiple times. If they have a vagal nerve stimulator, maybe they shouldn't have a magnet in their back. I mean, there's just a lot of things you have to consider as far as surgery goes. For me, the indications for surgery really are when everything else has failed and the scoliosis is more powerful than any of the other techniques that we've tried. And you can see by Mitch's talk, we've done just about everything under the sun here. I don't know if you guys have any other thoughts on indications or why you choose what you choose.
I think that's a good summary. So I think it's really, there's a whole thing called the early onset spine group that meets every year that spends 3 days arguing about which techniques is best.
I have just a concern about when things get quote easier to manage, then they get managed too frequently or too soon.
Yeah.
So you've got these fancy distraction rods that you can do with the magnet. But it still comes down to the sooner you start a growing rod, the sooner you'll run out of time. So you only have so many distractions to go. And so if you put that in a 4-year-old, you're going to run out of time way before you want to. So I still think that the delay strategies have to be emphasized, and there's going to be a temptation for people to go to a growing rod construct perhaps sooner because it's quote not as invasive and maybe less complications, but still the problem is you're immobilizing the spine, you can get spontaneous fusions, you can disrupt the rib cartilage vertebral articulation and cause of lung compliance. So delay is a good strategy here.
Any questions?